about vascular rejection in renal transplant pathology. So the most important thing is I'm going to show you few cases, and I just want to stress that vascular rejection uh, doesn't always mean that we are dealing with acute cellular rejection. Vascular rejection is a very common finding you get to see in acute antibody-mediated processes. So by all these cases and how clinically they behave, I'm going to highlight importance of picking up these vascular lesions and how many cases there was a repeat biopsy which was done, and what changes happened in the repeat biopsy. So I'm going to do a case-based kind of presentation, uh, and I'm going to discuss about just a basic part about vascular rejection, and then it will be more of a case-based thing. So as we know, Banff classification is important, and we all follow the Banff classification system whenever we talk about rejections and all that stuff. So I need not discuss about this thing. So it was in 1991, the first Banff meeting was conducted, and it got published in 1993. And in the Banff 1991 categories, there was a category of hyperacute rejection, which you hardly come across these days, because with a good immunopathological workup, you hardly come across these hyperacute rejections. You see these rejections mostly in an APO incompatible setting. At least in an APO compatible setting, it is very, I would say, a rare kind of a thing you get to see a hyperacute. But yes, in an APO incompatible, it is not that uncommon. Uh, now, in the 1991 categories also, if you look at, we used to label rejection as grade 1, grade 2, and grade 3. Grade 1 was a mild acute rejections in which there was significant interstitial infiltrate of, the infiltrate should be more than 45% of the total renal parenchyma, and there should be evidence of tubulitis. Okay. Uh, the grade 2 was called as moderate acute rejection, in which there was tubulitis, and along with that there was mild or moderate internal arteritis. We hardly use these terminologies. We say grade 1 as grade 1A or 1B. When we say 1A, that means the interstitial inflammation is more than 25%. Along with that, there is mild to moderate tubulitis. And in grade 1B, we say the interstitial inflammation is more than 25%. It is not based on the amount of interstitial inflammation. It is based on the severity of tubulitis. So if you find severe tubulitis, it becomes 1B. Then there is a type 2 rejection, which I'm going to discuss today. So type 2 rejections are vascular rejections. So I'll show you images and then you'll be able to understand. Then there is a type 3 rejection. Type 3 rejection is when you find fibrinoid necrosis of the vessel wall. That also I'll show you. So, which I've told you previously, antibody-mediated rejection, the hyperacute, and then there was another terminology which came as accelerated acute rejection. So this is the 1A, 1B, which I was talking about. So cases with significant interstitial inflammation, more than 25% parenchyma, and foci of moderate tubulitis, more than 4 mononuclear cells, or group of in a group of 10 tubular cells, or 1B, in which the tubulitis has to be severe tubulitis. That means you have to see more than 10 mononuclear cells. So I'm not going to show you cases of tubulitis or interstitial inflammation. I'm going to discuss only about the vascular lesions. So 2A and 2B is 2A and 2B vascular rejection is when you see mild to moderate internal arteritis, or 2B is cases with severe internal arteritis comprising of more than 25% of the luminal area. And cases in which there is a transmural, that means there is a transmural inflammation or transmural arteritis or fibrinoid necrosis of the vessel wall. These are called as V3 lesions. So just to highlight in this photomicrograph, you can see that this is a vessel. The spindle, this elongated cell, blue looking nucleus, is the endothelial cell. What you are seeing here, these are the RBCs. So if you see the endothelium or the spindle looking cell, endothelial cell, it is sitting on the intima. this is the muscle layer, this is media, and outside is adventitia. So there is tunica intima, media, and adventitia. Normally in a non-pathological vessel, you don't see any intima. Intima is seen only as a flat endothelial lining, which you can see here. So what is happening here is, just see, there is a flat endothelial cell here, and there are these dark looking round color lymphocytes. So when there are lymphocytes beneath the endothelial cells and they cause lifting of the endothelium. Just compare this endothelium, which is just flat, and there is lifting of the endothelium by these lymphocytes. So this is called as intimal arteritis or endotheliitis. Okay, and this is also called as an active vascular rejection. Similarly, if you compare this area with this area, you can see that here also these elongated cells are there, and there are some lymphocytes which are beneath the elongated cells. So there is endotheliitis, but it is not covering more than 25% of the vascular circumference. So this is like 2A or V1 lesion, vascular 1 lesion, or type 2A kind of rejection. So type 2A vascular rejection. Then there is another form of vascular rejection in which there is a lot of lymphocytes which are infiltrating into the just beneath the endothelial cells or in the intima, and it is covering more than 25% of the luminal area. So if you look at this lumen of the vessel, you can see more than 25% of the luminal area is showing this active endotheliitis. So this is called as type 2B vascular rejection. Then there is a type 3 vascular rejection where you can see here, you can see some muscle here, but here there is all fibrin. So there is fibrinoid necrosis of the vessel wall. These are the RBCs which you can see inside the lumen, and there is a lymphocytic infiltrate. So you can see lymphocytes here, you can see lymphocyte here, this area, this area. So practically it is transmural. So when there is a transmural arteritis or fibrinoid necrosis of the vessel wall, that is called as V3 lesion. It was commonly thought that V1, V2 lesions are commonly seen in acute T cell mediated rejection. Like these lesions are commonly seen in acute T cell mediated rejection, and V3 lesions are commonly seen because there is fibrinoid necrosis of the vessel. They are commonly seen in acute antibody mediated rejection. So I'll show you cases that. So the antibody mediated rejection in 2003, this article came, and it was based on the meeting which was conducted in 2001. There were some criteria of which were included for diagnosis of antibody mediated rejection, and one of these criteria was that there has to be a V3 kind of lesion. So this was a time that we used to believe that when there is a V3 lesion or severe vascular rejection, then only it is acute antibody mediated process. And V1, V2 lesions are not associated with acute antibody mediated process. Along with that, there has to be evidence of C4D positivity. There has to be capillary margination. When I say that means PTC capillaritis is there, or glomerulitis is there, or some thrombosis, that means TMA is there, C4D positivity, ATN, and very minimal inflammation. Because inflammation, if it is less than 10%, then only it is a minimal inflammation. If the inflammation is 10 to 25%, then it is a borderline cellular rejection. For acute cellular rejection, the amount of interstitial inflammation has to be more than 45%. Okay. So what I want to highlight here is that vascular lesion V3 or severe vascular rejection were only considered as part of acute antibody mediated rejection. So I'll show you cases by which I will try to highlight that without V3 also, it could be acute antibody mediated rejection. So I'll come to the case presentation. So this was a patient who was transplanted in 2005. Donor was wife. He had a CMV infection, and second transplant was done. Sorry. This was second transplant, which was their first transplant. First transplant was done in 2005. He had a CMV infection, and he had a lot of disseminated infection and all that. So, but he lost his graft. Then a second transplant was done. Donor was brother-in-law. The basic disease was unknown. No induction was given, and graft biopsy on POD6 shows there was rise in serum creatinine on POD6, and this is a graft biopsy. And the graft biopsy shows that there is diffuse acute tubular injury. So when I say acute tubular injury, normally the tubules are present in back-to-back manner. You hardly see here. What you can see is you can see tubules, but intervening areas you can see some spaces. and this space is called as interstitium. So there is some interstitial edema, tubules are separated, they appear dilated, and I want to highlight this vessel here. So you see some interstitial infiltrate, but that is very minimal. It is not like more than 25% interstitial inflammation. It is not even more than 10%. So there is some infiltrate which is there, but it is not more than 10%. But what you are seeing here is, so you can see here that there is a endothelial cell which is appearing like this. This is the normal looking endothelium, and this endothelium is lifted, and then you find lymphocytic infiltration here. So you can see lymphocytes which are infiltrating, and this is the endothelial cell. This is one plasma cell also which is seen in the just beneath the endothelium. So there is lymphocytic endothelitis, or there is mild endothelitis. When I say mild endothelitis, that means it is a 2A kind of vascular lesion because it is not involving more than 25% of the luminal circumference. Another area to highlight that there are lymphocytes which are causing lifting of the endothelium. Just compare this endothelium with this endothelium, you can appreciate that. These are the RBCs which are seen in the lumen. So this is a type 2A vascular rejection. There is hardly any infiltrate, but yes, there were few PTCs which are showing mild PTC capillaриtis, but and mild glomerulitis was also seen. And there was diffuse acute tubular injury. You can see these tubules. You can see the nuclei here, but no nuclei are seen here. So that means there is some loss of tubular nuclei here. And you can see that here there is a nucleus is seen, here the nucleus is not seen. And there is disruption of the tubular cytoplasm. So this was an isolated V lesion. Why I said isolated V lesion? Reason being, there is if had it been, there is interstitial inflammation which is like more than 25%. There is evidence of tubulitis. Along with that, I find that there is one vessel which is showing this kind of endothelitis. Then I will label this as an acute cellular rejection 2A. Now in this case, there is no interstitial inflammation. The PTC capillaриtis is also very minimal, not significant. The only pathology seems to be that there is one vessel which is showing endothelitis. So this entity is called as isolated V lesion, and previously we used to label this also. We can label this lesion as Banff type 2A rejection also. But you need to remember, for a Banff type 2A rejection, commonly you should find interstitial infiltrate as well as tubulitis. When you find no interstitial infiltrate, no tubulitis, only one vessel with endothelitis, which you are seeing now, that has to be labeled as isolated V lesion or isolated vascular lesion. So this patient received 5 doses of methylpred, and there was significant, and there was improvement, and serum creatinine came to the baseline. So this patient with a mild vascular rejection responded to steroid pulse, and he improved. So this isolated V lesion, there was a Banff 2009 working group which was formed just to understand what are these isolated V lesions and how do they clinically behave. So before I go into details of these isolated V lesions, I'll show you one more case. This was a 37-year male, 37-year male, wife was a donor, HLA 4/6 mismatch. Basic disease was diabetic nephropathy. He received IL-2 induction, urine output decrease on POD1, and graph Doppler showed increased RI, absence of diastolic flow with good perfusion. So what you are seeing here is there were two biopsies which was done. So there is good amount of interstitial infiltrate here. Now with this amount of interstitial infiltrate at low magnification, you think that, okay, we are dealing with a acute T cell mediated rejection because you can see these blue looking cells in the interstitium. As compared to the previous biopsy, this biopsy is showing good amount of interstitial infiltrate. Then another interesting point at this magnification, what you can appreciate is, you can see these tubules which are empty. They don't have anything in the lumen, but these tubules, some of the tubules are showing RBC cast. The moment in a transplant biopsy, early post-transplant, you see RBC cast in the tubule, you should always look for evidence of any vascular insult or a vascular rejection. So you can see there is good amount of interstitial infiltrate which is there. And so if you look at the glomerulus, so in the glomerulus, there is no evidence of any glomerulitis. So you see the capillary lumen, they are empty, they are not showing any lymphocytes. So there is no glomerulitis in this biopsy. This was a tubule, and you can see this tubule which is there, and you can see this. These are the tubular epithelial cells, and you can see one lymphocyte here. So there is evidence of mild tubulitis. In addition to that, if you look at the PTCs are congested and they are showing PTC capillaritis. You can see neutrophils, 1, 2, 3, 4 lymphocytes as well as neutrophils in the PTCs. Some of the PTCs are empty, but some of the PTCs are showing this. And you can also see some neutrophils in the interstitium and some RBCs in the interstitium. The moment you see RBCs in the interstitium or tubules in the or congested PTC or tubules with RBC cast, we should always look for vascular rejection. But there was no evidence of vascular rejection in this biopsy. C4D was negative. This is C4D immunofluorescence. So C4D, when I say negative, that means there is no staining in the peritubular capillaries. Normally in C4D immunofluorescence, you get to see mesangial staining. And that is how you know that your C4D is working, because normal glomerular mesangium should be positive for C4D, which was seen in this case, but there was no staining in the peritubular capillary. So it was C4D negative, and it showed, this case showed evidence of acute cellular rejection. I would say 1A. The only unusual finding was, yes, there was some PTCs which were showing congestion. There were few tubules with RBC cast, but there were 2, 3 evaluable blood vessels which were not showing any evidence of endothelitis. So patient was given pulse, but despite pulse therapy, there was no improvement, and the creatinine was rising further. So repeat biopsy was done. So this is a repeat biopsy which shows that the amount of interstitial infiltrate as compared to the previous biopsy has reduced. You can see these blue looking cells here, and in that it was like more than 45%, but now what you're seeing here is the ATN as compared to the previous biopsy has increased, because you see a lot of edema. You can see these are the RPCs in the interstitium. So there is some interstitial hemorrhage. There is ATN which has progressed. Okay. So there is acute tubular injury. Just compare this tubule and just see, you can see the tubular nuclei here, and there is complete flattening of the tubular nuclei, and you hardly see any tubular nuclei here. And you can see these RBCs which are there in the peritubular capillaries. That means there was peritubular capillary congestion, and RBC is also seen in the interstitium. That means there is some interstitial hemorrhage. So ATN has increased. Now, if you look at the PTCs, one PTC, second, third, all PTCs are showing cells. So that means there is peritubular capillaritis which has increased as compared to the previous biopsy. So two things have happened. The ATN severity has increased, and peritubular capillaritis, which was initially very minimal, now it is becoming moderate peritubular capillaritis. This is a silver stain to further highlight that these are the tubules which are there. You can see occasional lymphocyte here. These are the normal looking tubular epithelial cells, like round like this, and occasional lymphocyte you can see. So there is mild tubulitis, and the amount of interstitial infiltrate was very less. So possibly a borderline kind of infiltrate which was there. But yes, the PTCs were showing PTC capillaritis, which was like moderate. Now, if you look at the glomerulus as compared to the previous biopsy, the second biopsy is showing increased glomerulitis. You can see these lymphocytes in the capillary loops. You can see this lymphocyte here. You can see this lymphocyte here. So good number of lymphocytes are seen in the glomerular capillaries. So that means there is glomerular, there is microvascular inflammation which is there. So there is microvascular inflammation which was not seen in the first biopsy, but it is seen in the second biopsy. Now there was one vessel which was showing this kind of endothelitis. Now if you see this endothelitis, there is a smooth muscle layer which is there, and here there is some minimal necrosis of the smooth muscle layer. But important thing is, you can see these lymphocytes which are causing lifting of the endothelium. So there is evidence of endothelitis. So presence of endothelitis with microvascular inflammation in form of PTC capillaritis, glomerulitis, and not one vessel. There were two vessels which are showing this endothelitis. And if you look here, if you see the circumference also, luminal circumference, more than 25% of the luminal circumference is showing endothelitis. So that means it becomes a 2B. So one important thing, if you find in a transplant biopsy, more than two vessels or multiple vessels showing endothelitis, that is very suspicious of antibody mediated process. If you find only one vessel, I'm not saying that 100% this will be the scenario, but majority of the times, if you find extensive endothelitis, it is more likely to be acute antibody-mediated process rather than a T-cell mediated rejection. C4D, again, as compared to the previous biopsy, the present biopsy were also showing no significant staining in the PTC, except occasional PTC was showing very minimal staining, but it was not very strong. So clinically also, this patient was behaving like AMR. So this was labeled as C4D negative acute antibody-mediated rejection because by Banff criteria, if one occasional PTC showing minimal staining in immunofluorescence, it is considered as negative. On the other hand, by immunohistochemistry, even one PTC shows some staining, it should be considered as positive. So in this case, there were few things which suggested that this could be acute AMR. The ATN progress, the microvascular inflammation increased, and there was evidence of endothelitis, which was affecting more than one vessel. And this endothelitis was like 2A in one of the vessels, and it was like 2B in another vessel. Okay. So there was no V3 type of lesion, and the DSA was done in this patient. DSA was positive, and this patient responded to plasmapheresis, and serum creatinine came down to the baseline. So I'll show you another case. 28-year-old male renal transplant, which was done in 2014. There was graft dysfunction, rise in serum creatinine from 1.4 to 2.8. The first biopsy was done on POD5, and the second biopsy was done on POD12. So this is the first biopsy. So just see, looking at this biopsy, if you see blue cells in the kidney biopsy, that suggests interstitial inflammation. So in this, you hardly see very minimal looking blue cells. This is a vessel, a large vessel, and you don't see significant blue cells. So the blue cells are there, but this is a vein. So around the vein, also around the vein, you normally also you get some lymphocytic infiltration. So uh, whenever we try to quantify the amount of interstitial inflammation, we always ignore uh, infiltrate which is seen in the perivenular areas or around the vessels. So if we ignore this infiltrate, then we hardly have a minimal infiltrate which is seen here. But this vessel, look at this vessel. So this vessel is showing endothelitis. So you can see this, the present case was showing endothelitis. So this was like a 2B kind of, so there were two vessels. One vessel was showing a mild endothelitis like this, and this vessel, and there was another vessel which was showing endothelitis, which was covering more than 25% of the luminous circumference. So there was a 2B kind of rejection. If you look at PTCs were showing RBCs, but there was no neutrophilic or lymphocytic peritubular capillaritis. And acute tubular injury also was not that severe, very mild kind of acute tubular injury. You can see the tubules are arranged in back-to-back manner. There is no interstitial edema. So the ATN was also very mild or minimal. There was no glomerulitis. C40 was negative in the peritubular capillary. So this was labeled as acute cellular rejection, BAMP 2B. This patient received 5 pulses of methylprednisolone. There was no improvement in serum creatinine. And serum creatinine, on the other hand, was showing a rising trend. DSA lysate was done, which was negative. Now this is a repeat biopsy which was done because the patient was not improving, and the repeat biopsy, if you see here, it is showing all necrosis of the vascular endothelium. So there was progression of vascular rejection. So just compare, this was the first biopsy with a 2B kind of vascular rejection. There's a second biopsy which showing complete necrosis of the vessel wall. So that means it is a type 3 vascular rejection. And I have told you previously the type 3 vascular rejections are commonly associated with acute antibody-mediated process. So first biopsy is showing this, and they not one vessel. The second biopsy showed two vessels which are showing this kind of a severe endothelitis. So this also is showing a lot of luminal compromise. You hardly see, this is the lumen which is left. Just compare. This is a first biopsy where you can see lumen with RBCs, and this is a second biopsy in which one vessel is showing endothelitis, and there is complete luminal compromise. You see significant lymphocytic infiltration. And as compared to the previous biopsy, also the present biopsy show there was some PTCs which were showing peritubular capillaritis. So there are some PTCs which are empty, which are not showing any cells, but there were some PTCs showing neutrophilic peritubular capillaritis. The ATN also, ATN was not, I won't say that there was significant increase in the intensity of ATN. ATN was towards some milder side. If we look at the glomerulitis, so first biopsy was showing no glomerulitis, and the second biopsy, repeat biopsy, it showed a few glomeruli showing significant glomerulitis. So when I say glomerulitis, that means there are no cells within the capillary lumen. So in a native kidney biopsy, if you find inflammatory cells in the capillary lumen, you label it as endocapillary proliferation. But in a transplant biopsy, if you find inflammatory cells in the capillary lumen, you label it as glomerulitis. So there was increase in microvascular inflammation. There was increase in by microvascular inflammation, I mean there is glomerulitis, there is peritubular capitis. There is evidence of vascular rejection. There is progression of vascular rejection from 2B to type 3 vascular rejection. And even the C4D positivity, which was negative in the first biopsy, the second biopsy showed some PTCs plus some staining. But as I have told you, less than 10% PTC staining in immunofluorescence is considered as negative. So this was a isolated V lesion, classical isolated V lesion, because there was no interstitial inflammation at all. And yes, this patient he clinically behaved like AMR. Even the biopsy findings suggest that in the last biopsy, there was complete fibrinoid necrosis of the vessel wall, which is consistent with AMR. And I must tell you that you should not depend on C4D, because C4D is mostly negative in acute antibody mediated processes or acute antibody mediated rejection. If C4D is positive, you are very lucky enough that C4D has come positive, but otherwise, majority of cases, in my experience, whenever you see acute AMR, they are C4D negative. So it is based only on morphology you give this diagnosis. I'll show you another case. This was a recent biopsy which came 3 days back. This is a POD3 post-renal transplant. This was POD3, and what you can see here, this is a PS stain. There is complete necrosis of the tubules here. So one portion of the renal cortex is necrotic. So it was like 15 to 20% of the cortex which was necrotic, and the rest of the cortex is viable. So if you look at this necrotic cortex, just compare as compared to the very blue looking cells, what you can see here, you see here it is more pink. So whenever there is a necrosis of the tubule or necrosis of the renal tissue, it appears less blue and it appears more pink. Okay. This is a high magnification of these necrotic tubules. You should remember that whenever the necrosis occurs, the first tubules which go are proximal tubules. So proximal tubules are larger in size. You can see the larger size, and you can see complete loss of tubular nuclei. You hardly see. And just compare this with distal tubule. You can see this distal tubule where nuclei is intact. So distal tubule is not showing any necrosis, but the proximal tubule is completely necrotic. Even if you look at this glomulus also, there are some lymphocytes in the glomerular capillary loop, but there is no supporting mesenchyme. So this is called as mesangiolisis. So there is some inflammation in the renal cortex, but that inflammation was very minimal. Now, there were 2-3 vessels which are showing endothelitis. So this is a very minimal kind of endothelitis. What you can see here, you can see these endothelial cells, and the lymphocytes are not lying beneath the endothelium. It is in the luminal side. So this is not endothelitis. For endothelitis, there has to be lymphocyte which should be lying beneath the endothelium, as you can see here. So this is endothelitis. This is endothelitis because you can see the lifting of the endothelial nuclei. There was another vessel which was showing similar endothelitis. Okay. And one more vessel which was showing. So multiple vessels showing endothelitis, though there is no microvascular inflammation, no glomerulitis, no PTC capitis, but still presence of 3 vessels showing different degrees of endothelitis, presence of even with absence of C4D positivity. So we need to raise a possibility that there could be acute antibody mediated process. So this patient also, he has received 3-4 pulses, because this is like as I told you 3-4 days back the biopsy was done, but despite receiving pulse therapy, there is no significant improvement in the serum creatinine. And there were some PTCs which were showing PTC capitis. The DSA was done. No, I don't think DSA is being done in this case. but I raised a possibility based on the morphology and based on extensive vascular involvement and some peritubular capillaritis that possibly we are dealing with a acute antibody mediated rejection. So this, and there is a pachycortical infarction also. So there could be two possibilities. Either it is a pachycortical infarction due to vascular involvement, that is, or vascular involvement could be due to AMR or could be due to acute T cell mediated rejection. But we need to remember important thing that when there is extensive vascular involvement or when there are multiple vessels showing endothelitis, you should always keep AMR as one of the possibilities. So this was my last case, and what I wish to highlight by all these cases is that don't depend on C4D for diagnosis of antibody-mediated rejection. There could be vascular lesions which could be just mild to moderate endothelitis or even a severe fibrinoid necrosis of the vessel walls also. So you need to see overall that if you find extensive vascular involvement with some microvascular inflammation, even in the absence of C4D positivity, you should think of acute antibody-mediated rejection. And if in a vascular rejection, patient is not showing any significant response, then you need to go for a repeat biopsy, because many a times repeat biopsy can show C4D positivity or repeat biopsy can show progression of disease. As I've shown you in one case, there was progression of vascular rejection from 2A, 2B to type 3 kind of vascular rejection. So if there are any queries you want to ask me, you can go ahead, or in the chat box you can message and I can answer in the chat box. So I made it short because I thought that we have to deal with only a vascular lesions, because it is easy to diagnose tubulitis and interstitial inflammation and all that stuff. But vascular lesions, many times vascular lesions are missed on routine biopsies. Reason being, when we receive a renal biopsy sample, majority of the time there are 2 or 3 vessels only which are sampled. So if there is, so we need to look very carefully as pathologists. Majority of these vessels in the serial sections and the multiple sections, and so there will be a hint that we possibly are missing on vascular rejection if I find there is interstitial hemorrhage. If in the biopsy I find tubules with RBC cast, all these findings suggest that I need to look carefully and I need to look for any evidence of vascular rejection. The other thing is, there are some articles which say that if you find eosinophils in a transplant biopsy, you should also look for vascular rejection. And we have to remember that eosinophil presence could be related to interstitial nephritis also, because if the patient is taking some antibiotics and all that stuff, so you can find some eosinophils. But always remember, if you find tubules with RBC cast, if you find some eosinophils, try to look for evidence of any endothelitis. Because that endothelitis, if it responds to steroid, then it is fine. But if it is not responding to steroids, then it could be a manifestation of acute antibody-mediated process. And always remember, vascular lesions are very commonly seen in acute antibody-mediated rejections. So if you have any questions, you can ask me. So either you have understood everything. The other thing I want to highlight is that if with all these things, if you find classical findings of acute AMR in the biopsy, you find DMA and all that, then life becomes easier, that you can for diagnosis of acute AMR, then there is no problem. But what I have seen in majority of the cases, when there are vascular lesions, you don't get to see a thrombotic microangiopathy. TMA is a very common finding we see in AB incompatible transplants. Okay, but TMA. Okay, so the question is ABMR with negative DSA, how common it is? So it is not very common, I must tell you, but we need to remember what type of DSA you are doing. If you are doing DSA lysate, it is possible that that is not a very good methodology. So you have to do a single antigen beat. So even with single antigen beat, if morphology is very significant, that morphology is like classical of acute AMR, and then also DSA is negative, it is possible because there are anti-endothelial antibodies. There are some non-HLA antibodies which will not be picked up by your luminex. Okay. How much is the percentage? I'm not very sure. It could be maybe 4-5%. I'm not very sure about that because I don't look at the immunopathology part. I look at only the histopathology part of renal transplant. But yes, we have seen cases where morphologically, I say, I'm sure that it is acute AMR. They they get the single antigen bead assay, but not very common. They get the single antigen bead assay. I remember 2 days back only there was case recent transplant. Yeah, this patient went on a ventilator. Obviously, the immunosuppression was reduced, and there was renal dysfunction. They thought it could be ATN, it could be rejection. They repeated biopsy. All the vessels, there were around 5-6 vessels, they were showing moderate endothelitis. And I was sure that we are dealing with most likely acute AMR, but C4D was negative. Even they got the DSA done, DSA was also negative. But patient received plasmapheresis and pulse therapy. But there was no significant improvement in the serum creatinine. Serum creatinine went up to 7, uh, got reduced to 5 or maybe 4.5, but then it is stuck at 4.5. So we are not sure. Now, most likely they are going to do a repeat biopsy on that. But yes, we come across cases in which TSA by single antigen beat is negative, but not very common, I must tell. Possibly 10% or not more than that. Because anti-endothelial antibodies will show some kind of a vascular injury or vascular involvement, like in form of endothelitis. Yeah. So important thing, if you find more vessels with endothelitis, think of AMR as one of the possibility. If there is no interstitial inflammation, if there is no tubulitis. Minimal tubulitis you can see even uh, in AMR if it is associated with some amount of T cell mediated or borderline cellular rejection. Any more questions? You can write in the chat box. So I can ask you, for when we say mild tubulitis, is there any quantification of lymphocytes for mild, moderate, and severe tubulitis? How many lymphocytes should be there in tubular cross section? In one tubular cross section. For mild tubulitis, how many lymphocytes should be there? You can write your answers in the chat box. No answer is coming. So it is said that 1 to 4 lymphocytes per tubular cross section, that is mild tubulitis. If you find 4 to 10 lymphocyte per tubular cross section, that is moderate tubulitis. And if you see more than 20 lymphocyte per tubular cross section, then it is severe tubulitis. And vascular rejection, I've told you that if it is involving less than 25% of the luminous circumference, then it is a mild vascular rejection or 2A type of vascular rejection. And if it involves more than 25% of the luminous circumference, then it is 2B. And if you find transmural or fibrinoid necrosis of the vessel wall, then it is a type 3 vascular rejection. So any more? So I'm waiting if there are any further questions. You can write in the chat box.
Hello.
Hi, Puneet.
Sir, yes, sir.
I feel that everyone has understood everything.
Yes, sir. Uh-huh.
Okay, so
So,
done.
fine, sir.
Okay, ji. Thank
Thank you.
you.
Thank you so much, sir. Thank you so much.
Thank
Again,
you. Thanks a lot.
yeah.